Well, hello everyone, and welcome back to our multiple sclerosis continuing medical education series. My name is Lucas Kipp, and I'm a clinical assistant professor and MS specialist here at the Stanford MS Clinic in Palo Alto. In our last lecture, we explored how to recognize and diagnose multiple sclerosis. And today, we'll discuss the different phases and phenotypes of MS, introduce the concept of neurologic reserve, and highlight the importance of early treatment to improve long-term outcomes. By the end of this talk, I hope that you can summarize the benefits of early treatment in MS and be comfortable encouraging this approach that incorporates both pharmacologic and non-pharmacologic therapies to your patients. So I'd like you to recall our patient with transverse myelitis at age 27, followed by optic neuritis at age 28, and diagnosed with relapsing remitting MS that we talked about in the last lecture. So this patient was initially started on what's called platform therapy or first-line therapy following their diagnosis. And this generally refers to the older injectable therapies like the interferon class or glatiramer acetate that's been used since the 1990s. So our patient did pretty well on this therapy for about 5 years, until they had an episode of double vision. When an MRI was done at the time of the double vision, it showed a new enhancing lesion in the pons, which certainly explains the patient's symptoms. But we also saw multiple new but non-enhancing lesions in other areas of the brain. And these are lesions that would have formed in the 5 years without us knowing them. Now, the patient did well when they were treated with steroids, and appropriately, their MS therapy was changed, this time to a somewhat more highly efficacious oral therapy. And they remained clinically and radiographically stable because now someone was actually doing their MRIs more frequently for the next 10 years. But in the last 1 to 2 years, the patient had noticed that they were slowly getting a little bit worse. Their legs were a little bit weaker. They didn't have as much endurance. They were more imbalanced. And yet there weren't any changes on follow-up MRIs. So I want you to ask yourself, what do you think is happening here? How are you going to explain that to your patient? Why are they worsening despite an unchanged MRI? And what are you going to do? By understanding the natural history of MS and the concept of neurologic reserve, I hope that I can give you the tools to answer these questions by the end of the lecture. So over the last 2 decades, we've typically used this illustration to show how untreated MS proceeds over someone's lifetime. There's this preclinical phase during which patients are developing MRI lesions. So that's depicted here with the arrows. But they haven't yet exhibited clinical symptoms. So this is referred to as radiographically isolated syndrome, or RIS. And you might be asking, well, how do you know this exists if patients don't have symptoms? Well, we know this stage exists because people get MRIs for many reasons, including things like headaches, for example. And sometimes we see changes that look just like MS. But as we discussed in lecture 2, we can't make an MS diagnosis yet without clinical symptoms. Now, remarkably, approximately 90% of lesions in the supratentorial brain, in the big cerebral hemispheres, they actually don't immediately lead to clinical relapses that the patient can feel. Now, when they occur in an eloquent area, like the optic nerve that's controlling vision or the spinal cord, for example, they're much more likely to be symptomatic. And when those first symptoms occur, we call it clinically isolated syndrome if they don't yet meet diagnostic criteria for MS. Now, once they have another clinical attack or new lesions on MRI, by that time we call them relapsing remitting MS because they've shown repeated inflammation in time and space. So this phase of the disease is called the relapsing remitting phase. And for most people with MS, this phase generally continues to occur over about 10 to 15 years. Now, this is really driven by inflammatory activity, and inflammatory activity is really characterized by the appearance of new lesions, the arrows, and new relapses. Okay? However, the probability of new relapses and new MRI activity actually goes down year by year with MS. And yet, despite this, later on in life, their disability continues to increase, even when the MRI generally stops changing. So what's going on here? This is the stage called the secondary progressive phase of MS. Secondary because it happens after relapsing remitting, and progressive because clinical symptoms that they developed earlier in life just slowly get worse over time, even in the absence of new MRI activity. And if left untreated, about 50% to 60% of people with relapsing remitting MS get to this stage by 15 or 20 years. And so this is the stage that our patient had been slowly transitioning to in our case. Now, one of the big challenges here is that there is no definitive biomarker that heralds this stage. It really relies on the patient telling you that their symptoms are slowly worsening and you objectively documenting worsening on their neurologic exam. Now, what's this? What's primary progressive MS? Well, primary progressive MS is just slow accumulation of disability, this very slow onset of worsening symptoms since the onset of their clinical symptoms, without this preceding relapsing remitting course. Now, what's interesting is that the average age of diagnosis of primary progressive MS is at least 10 years older than those with relapsing remitting MS. But by the time it starts and patients are aware that something's going on, it really follows the exact same trajectory as we see for secondary progressive MS. And what I'll show you in some coming slides is that PPMS is likely just MS where this activity was occurring on MRI, but they were never aware of it until enough disease, enough had accumulated where the nervous system couldn't keep up. And they just slowly started deteriorating after that. Now, in both forms of progressive MS, while MRI lesions are generally no longer forming, what we do see is ongoing brain volume loss. Brains are shrinking at a much faster rate than we'd expect than the general population. And so this is one of the proposed explanations of why the disease is worsening even when the MRI isn't changing. In terms of nomenclature, I just wanted to let you know that progressive MS can also be further classified by two other parameters. One, you can have progressive disease that is active, meaning you can still have some relapses from time to time with secondary progressive MS, or new MRI activity. Both of those things would be considered active secondary progressive MS. And then progression is really meant to define that steadily increasing objective worsening on their neurologic exam. Now, ideally, with therapy, patients are neither active nor progressing. But as you'll see, our therapies aren't very good with progressive disease. And that's why it's so important that we prevent people from getting there in the first place. So, what is going on in these progressive stages? And I think the concept of neurologic reserve and accelerated brain atrophy offer a pretty good explanation. So, what is neurologic reserve? Well, neurologic reserve is the finite capacity of the central nervous system to compensate for injury and remodel itself. And so brain volume is a major component of that reserve. So what I'm showing you here is a topographical model of MS. And I think it's a helpful way to think about those clinical courses of MS that we just talked about in the context of this neurologic reserve and brain volumes. And I think it's also a really useful way to illustrate what's going on to patients. And so I actually draw out this to patients that I see in clinic who are making this transition into progressive disease where their MRI isn't changing. So if you think about an individual's neurologic reserve as a pool of water, that pool is as full as it's going to get by the mid-20s or so. You've got your most brain volume by that age. And then slowly, even just a normal part of aging, we lose a little bit of brain year by year. So even patients in early MS, they've got a pretty good pool of water. Now, when lesions form, they're taking away some of that pool and the water level's coming down a little bit. And you can see that that water level is really the clinical threshold if patients are going to experience symptoms or not. So if you get lesions that form in the deep end of the pool, like the big cerebral hemispheres, you might not feel them at all. Versus, like I talked about, if you get lesions in eloquent areas like the spinal cord or optic nerve, it's much more likely that they're going to cross that surface and the patient's going to be alerted to them. However, say this was a lesion that affected strength in the right leg. That might not be immediately apparent to the patient, but it's causing irreversible injury. That pathway has always now been involved. And it might take a number of years until the brain volume decreases enough, the neurologic reserve decreases enough, where all of a sudden it slowly becomes apparent that that right leg strength is getting worse. And so, this very much seems like what relapsing remitting is like early on. But then as that water level goes down, those brain volumes decrease. That also explains why people can slowly progress, even if new lesions aren't forming. And if we think about it in terms of primary progressive MS, you can imagine that primary progressive MS is probably just that these lesions are forming always below the surface. And it's not until enough of that reserve is lost till things slowly get worse over time as you're losing that brain volume. So I hope this analogy is helpful to illustrate, how MS-related damage can go undetected during early phases of the disease, like in RIS, and why disability continues to accumulate in progressive MS, both secondary or primary progressive, even in the absence of new MRI lesions. And kind of rather than thinking about all of these different, phases as different diseases or different diagnoses, you can really see that they exist kind of on a continuum. And it's also clear that progressive disease then is going to start when that neurologic reserve is exhausted. So we want to maximize and preserve this pool from day one with early and optimal MS therapy. That's really crucial here. So conceptually, one can imagine that the earlier the diagnosis and the earlier the treatment, this must have long-term advantages to keeping that pool of water full and also the biggest opportunity to change the course of the disease. The longer you wait, the range of good outcomes or the likelihood of good outcomes is less. And in the next few slides, I'm going to show you some examples that prove that that's true in multiple sclerosis. So, although we generally think of MS as a demyelinating disorder, the truth is that every single MS lesion that you see on MRI has actually caused irreversible axonal loss. And it's actually up to 11,000 axons per millimeter cubed of brain lesion. And that's axons that the patients never get back. And that's the main determinant of irreversible clinical disability in multiple sclerosis. And we know that this axonal loss is apparent even in the really early stages of the disease, even as early as the radiographic isolated syndrome, where those lesions are forming, people are irreversibly losing brain tissue. It's not just something that's happening later. The other thing that we know is that in non-lesional white matter, meaning even the places outside the white spots on MRI, that isn't actually normal either. And sometimes we refer to it as the normal appearing white matter because we can't see what's going on conventional MRI. But we know that people with MS are losing more axons in even that area that looks fine on MRI compared to people that don't have MS. And that loss of axons that we're talking about is reflected in accelerated brain atrophy in patients with MS. And this is what it looks like on MRI. As you lose brain tissue, the cerebral spinal fluid, which is black, starts to fill in the gaps. And so your ventricles get bigger, the sulci between the brain tissue get bigger, and you fill it in with this cerebral spinal fluid. And this brain atrophy occurs about 3 to 5 times faster than in healthy adults. Now, this figure is meant to illustrate how brain volume decreases over time in someone that's just been diagnosed at age 25 with MS. And what you'll see if you look at their brain volumes, in just 5 years, that MS patient's brain volume has dropped to essentially what a healthy 70-year-old's brain looks like. So this brain atrophy is occurring rapidly, and it's occurring early in the course of the disease. So we need to intervene as early as we can to stop this. In addition to atrophy and brain volumes, the early clinical course can give you a clue of where this patient is headed. And, it influences long-term outcomes. So in this table, what we're looking at is the median time that it takes for progressive disease to start. So for the onset of secondary progressive MS, when we know that our reserve has already failed and we're too late. And that actually depends on how frequent the relapses are in the early years, as well as the time between the relapses. So just the patient's clinical history can give you a sense of how much do I need to worry about this patient and get them on therapy right away. And what we can see from this table alone is that the time to the onset is reduced significantly in people who have 3 or more relapses in the first 2 years, or if their time between attacks is less. Another compelling reason for early treatment is the fact that MS therapies work better earlier. So what this is a forest plot from a recent meta-analysis of numerous phase 3 clinical trials on multiple different disease-modifying therapies. So all of these lines are different disease-modifying therapies for MS. And yet they all show the same thing. They all work better in patients that are younger. And in this, it's defined as less than 40 versus older patients greater than 40. The drug's effect is less in the older patients. Now, this is also true of people who are less disabled. So if you have an EDSS score, which is our disability score, which is basically a quantitative neurologic exam, for EDS scores less than 3.5, these figures look very similar. And the drugs work better if you're less disabled. So we've shown a few examples that, early course, younger patients can influence, the outcomes, but does earlier treatment actually make a difference long-term? And yes, there's many studies that show that earlier treatment can delay the onset to higher disability levels or the onset of progressive MS in the first place. So this is just a visual representation of what our EDSS disability scale looks like. So an EDSS of 6 means that they already have to use something to help them walk, like a cane, for example. And on the left here, this is looking at the probability of reaching an EDSS of 6, in which an individual has to use a cane to walk, is less likely if they're treated early. And on the right, we're looking at a similar thing, only we're looking at the probability of the onset of progressive disease. And you can see that the onset is much less likely when you're being treated. To give another example, and one that I think puts things into understandable terms for patients, is in one study, we showed that the risk of reaching an EDSS of 4 is increased by almost 10% each year that treatment is delayed. So we know that early treatment is important to prevent these higher and later disability levels. And I think perhaps the most compelling data on the timing of early treatment and its effect on disability progression is a recent study from 2020 using the MS-based data set. So MS-based is a registry of over 80,000 MS patient records from over 150 clinics over 40 countries. And here, researchers compared long-term disability outcomes between patients who started on high efficacy therapies, which are the group in blue, within the first 2 years, versus those who started on high efficacy therapies, but not until years 4 to 6 after disease onset. And what they showed is that the early treatment group with these high efficacy therapies had overall lower disability scores and a lower likelihood of disability progression than those who started on treatment much later. So not only is early therapy important, but our window for this early treatment may be as early as the first few years in making the biggest impact long-term. So far we've talked about a number of compelling reasons for early treatment in MS, including the irreversible axonal loss, the rapid brain atrophy, how early symptoms and course influence the long-term outcomes, the fact our medications work best in younger patients who are less disabled. And this illustration illustrates a number of others that you can read as well that we don't have all the time to go into for today's lecture. Now, one of the main reasons why this early course is important is because it's very inflammatory. And it's this inflammatory phase that's the target of our FDA-approved MS therapies. So it's kind of no wonder our MS therapies work better in younger people who are more inflammatory and less disabled. And if we protect against that inflammation early in the course, we're going to preserve more of that neurologic reserve. But what we haven't talked about is that that's not the only thing that determines the benefit-risk ratio of our therapies. The other thing that's happening over time is not only is the inflammatory part of MS going down, and so our treatments are going to get less effective, but the risks of our treatment are going up because the patients are getting older and developing other medical comorbidities. But overall, the benefit risk ratio is declining over time as well. So we really want to intervene as early as we can when we've got the healthiest patients and the best ability to make a difference in their long-term outcome. So what can we do to maximize and sustain neurologic reserve? Well, no matter if you're a primary care, nurse practitioner, PA, nurse, neurologist, MS specialist, there's a number of non-pharmacologic interventions that can make a difference. And really the first is promoting a healthy diet and vitamin D supplementation. Now, we talked about a number of these modifiable lectures in our, or modifiable risk factors in our first lecture, but just to recap, we know that vitamin D supplementation reduces relapse rates and new MRI activity. And, we have a target serum level that is not associated with toxicity, so there's very little harm. And even though we don't have a specific MS diet, we know certain things that are important for brain health and also cardiovascular health that are also important. And so some of these are listed here. We also know that promoting cardiovascular fitness actually correlates with brain volume and cognitive reserve, particularly processing speed. There's also other benefits to exercising, like reducing fatigue, improving mobility, and patients actually rate their quality of life higher if they're exercising. Our guidelines are not overly specific, but recommending at least 2 times a week of cardiovascular exercise, getting that heart rate up moderately for at least 30 minutes, and also 2 days a week of strength training of major muscle groups. We talked a lot about smoking in our first lecture as being a risk factor in MS, but also cigarette smoking is harmful, in patients that already have MS. It's associated with decreased brain volumes, higher relapse rates, higher rate of disability progression, more cognitive impairment, and of course, reduced survival. So that's something that any practitioner can counsel patients on. We also can maximize reserve by minimizing and treating some of these medical comorbidities, particularly the vascular risk factors. And the reason why vascular risk factors are important to treat is because they affect the small blood vessels in the brain. And so if you damage those small blood vessels in the brain, that's another way that the brain can be injured on top of MS that you've already got. And that can also contribute to brain atrophy. And we've got data that shows that people with hypertension and heart disease actually have lower brain volumes. We know that obesity is associated with more brain lesions. And we know that all of the risk factors listed here are associated with increased disability progression if they coexist at any time in the MS disease course. Now, of course, minimizing disease activity with MS disease-modifying therapies is a key component to maximizing neurologic reserve. And all of our therapies have some effect on relapse rates and MRI activities and preventing new lesion formation, which I've mentioned are causing irreversible axonal loss. But as you can see from this chart, not all therapies are created equal, and some work much better than others, which I'm going to explore in our next lecture. And it's only really the high efficacy drugs that have been consistently shown to slow brain atrophy into a normal range that we'd expect for healthy controls, which is somewhere between 0.2 and 0.4% per year, which is why I'm going to emphasize not only the early use of therapies, but the early use of high efficacy therapies in our next lecture. Putting this all together, I think this is a good way to conceptualize what's going on in our different phases of MS going forward. So we know that brain atrophy is accelerated and is playing a role even very early back here in RIS and CIS. We know that that shrinks the neurologic reserve. And when that neurologic reserve has failed or is exhausted, that's when people develop this slowly progressive disease. And arguably, we're too late to make a big impact on their long-term disability if we wait this long. And so we really want to be treating patients back here so that they have the best likelihood of not being disabled or reaching that progressive disease at all, where our drugs don't work very well. And so looking back at our case, I hope that you can recognize that what this patient was experiencing was that transition to secondary progressive MS. And utilizing a topographical model of MS, you could draw that out for a patient and explain the concept of neurologic reserve when you've got them in clinic with you. And while this patient was treated relatively early, at least in the first 2 years of therapy, I think this case also brings up some important points about the initial choice of therapies. I mean, should we still be using these first-line therapies anymore? What do we do for disease monitoring? You know, this patient is someone that didn't have an MRI for 5 years because they said they felt fine. But when we did do another MRI, they had all of these other lesions that had formed asymptomatically in the interval. And any one of those would have been an indication that the drug that they are on isn't enough to keep all their disease at bay. And so it also brings up the concept of, what are our goals of therapy? Should we be targeting them just to what a patient tells you that they're experiencing, or should we be targeting it to disease that we're seeing on MRI as well? And we're going to explore these issues in our next lecture. So what I wanted to leave you with was these take-home points. The number one thing is that time is brain. And brain atrophy, neurologic reserve, they're all rapidly declining, even in the earliest phases of the disease. When that neurologic reserve is exhausted, that's when the treatment-resistant progressive disease starts. But we've got a lot of things we can do to prevent that or push that into the future with both pharmacologic and non-pharmacologic interventions. And just know that treatment during the earliest, most inflammatory stage of MS is the most important thing that we can do to change the trajectory of the disease and delay or avoid progressive disability down the road. So this concludes our third lecture on MS. And I hope you join us next time when we'll be discussing MS therapies, emphasizing the use of high efficacy therapies early in the disease course, as well as the concepts in monitoring MS and our goals of treatment. These are my references. Thank you very much.